Hey YouTube, welcome back to my channel. My name is Dr. Daniel Kaplan, and my mission is to make psychology accessible to all. And in today's video, we're going to talk all about autism spectrum disorders. And for many, you're familiar with autism spectrum disorders. You probably have heard it referred to as autistic disorder. You probably have heard the term pervasive developmental disorder. You probably have heard the term Asperger's disorder. And in today's video, you're going to learn that the DSM-5 collapsed these conditions into one broader umbrella called autism spectrum disorder. So in addition, we're going to learn all about the features of autism. We're going to learn about the frequency by which it occurs. We're going to discuss some common causes or explanations for the condition and some frequently used treatments. So if you like what we have to offer and you find the information in this video useful, hit the like button, subscribe to the channel, click the notifications tab. These three actions help this video reach a broader audience, so I need your help. So without further ado, let's get into it. As I mentioned, the DSM-5, which is the manual we use for assessment and diagnosis of mental health conditions, consolidated autistic disorder, Asperger's disorder, and pervasive developmental disorder into a more umbrella category called autism spectrum disorder. And that was based on the understanding that the symptoms of these disorders actually represent a single continuum that goes from mild to more severe impairments on two factors, two domains: social communication and a more stereotypical, restrictive, or repetitive behavior interests. And this change was designed to help improve our sensitivity and specificity for the diagnosis to make sure that we can identify more focused treatment targets as needed. So let's get into it. In general, we see autism spectrum disorders are marked with social impairments, communication deficits, and inappropriate responses to stimuli. Now, this particular condition was first identified and labeled in 1943 by Otto Kanner. So you might hear the term Kannerian autism, which is the more traditional autistic disorder. But when we look at it, we tend to see very stereotypical, rigid, or repetitive patterns that emerge very early in childhood. The symptoms usually occur before the age of 3. And for that reason, the American Academy of Pediatrics recommends doing an assessment at 18 months and 24 months. And we'll talk about this a little bit later, but early detection results in better prognosis. So these assessments that the AAP are suggesting actually are designed to help. So let's get into it. The prevalence of autism spectrum disorders has increased continuously. So if we look at from 2000 to 2018 being the surveillance years, there is this continuous increase in prevalence, which you see it goes from 1 in 150 all the way down to the most current number from the CDC of 1 in 44. So the rates of autism spectrum disorder are indeed increasing. And there are several explanations for it. One is that our awareness about autism has increased, so we're able to detect it better. So there's more education for parents And also the change in criterion in the DSM-5 might also explain some of the increase in the prevalence. We know that autism spectrum disorders do not target a specific racial, ethnic, or socioeconomic group. Everyone is fairly equally prone to the condition. And in terms of gender differences, we know autism spectrum disorders are roughly 4 times more common among boys relative to girls. So if we are understanding the long-term course of the condition, about 90% of children with this disorder remain significantly disabled into adulthood. And even the highest functioning adults, maybe the people who used to be referred to as having Asperger's, they still have deficits as it relates to social communication and restricted activities. So as it relates to social communication, we tend to see a couple issues that go on. There's a lack of responsiveness, so inappropriate response to social reaction. There's also a lack of social reciprocity, understanding the roles of communication, understanding turn taking. You might see more intrusive behavior into other people's conversations, or what people say, butting into the conversation. So we see that even with the highest of functioning individuals on the autism spectrum, in terms of language and communication, a hallmark feature, or a common feature, I should say, is echolalia, where instead of the person responding to what's being said, they merely repeat the phrases being spoken to them. So if I were to say, "How are you?" a natural response is, "I'm doing well, thank you. How about yourself?" Whereas a person with echolalia, if you say, "How are you?" they are going to respond, "How are you?" repeating exactly the phrase spoken. Another issue that we see with autism spectrum disorder in language is what's called a pronominal reversal, which is a confusion of pronouns: I, you, he, she, they. These get flipped and confused. They're very common. Now, there is also a rigidity, we said, with autism spectrum disorder. There's something called perseveration of the sameness. Individuals on the autism spectrum prefer predictability, prefer things to be done the same way in the same sequence, and are fairly rigid about their play patterns, their sleep schedule, their eating patterns, etc. So people usually have a schedule of the day when they're working with individuals on the autism spectrum. And for parents, we start to talk to them about making sure they build in transitions. So if you're going to deviate from the ordinary schedule, let your child know, let them know what's going to happen. And it's not even a bad idea to have a countdown. In 30 minutes, we're going to do ... 15 minutes left ... And what that does is it addresses the dysregulation that can occur due to things not being the same. So you're going to run the risk of having fewer meltdowns if you build in transitions. We also see that there is a strong attachment to objects. So it could be, collecting every car, G.I. Joes. It could be Power Rangers. It could be video games. And these objects take on a life of their own, and they become very important. So if a kid has a strong attachment to video games, they might have obsessive behavior about making sure their video games are put away, making sure they're in a secure location that goes beyond what is expected in childhood. We also see dysregulation of motor movements. So we see self-stimulatory behavior, things like hand flapping, that is very, very common. Walking on one's toes, making certain facial grimaces. These are very, very common self-stimulatory behaviors. But we also have something called self-injurious behaviors, which are incredibly concerning, and we have to take care of them. Things like a child rocking back and forth, that would be self-stimulatory. But if they rock back and forth and they bang their head against the wall, that head banging can cause significant harm. Biting, scratching, things like that. These are additional common self-injurious behaviors that we have to work to eliminate when we're treating an individual on the autism spectrum. Another feature that can occur is catatonia, which is a motor dysregulation where a person is either less responsive to motor activity and they might become statuesque or frozen in time, or they could have wild excitement of moving their hands around in a dysregulated way too. So we can have catatonia, not on the slide, but it's worth noting. So you might ask yourself, well, what causes autism spectrum disorder? In this video, I am not going to cover all of the origins or the risk factors, but I want to introduce to you some of the common explanations people say. One is a form of a cognitive disturbance or a central perceptual processing issue. And the manifestation of this cognitive deficit is something called difficulties with theory of mind. So theory of mind is our awareness that people have their own beliefs, their own behaviors, their own thought processes. And we have the ability to understand that a person's thought process could be different than our own. When you have a child on the autism spectrum, they struggle with being able to understand other people's points of view, which we refer to as theory of mind difficulties. Now, a sociocultural cause that has been proposed but doesn't really have as much support is family dysfunction, right? So if there's a lot of conflict in a home, perhaps that causes autism spectrum disorders or some kind of social environmental stressor. The research is very, very limited in terms of support for this, so we tend to say this is unfounded. In terms of biological factors at play, we know that there is higher rates of autism among siblings and twins, which suggests that there might be a genetic predisposition for autism spectrum disorder. And we also know that there are various brain regions that are at play. In particular, the cerebellum has been implicated in autism spectrum disorders, amongst others. If you're interested in a really good case study, look at the case study of Temple Grandin. They studied her brain and they came up with additional explanations. One thing that I would like to correct, there has been a statement that immunization or getting shots in children, particularly the MMR, has some risk for the development of autism spectrum disorders. That is unequivocally false. The research that was done on this was fabricated, but it did become very popularized, and so we struggle to break the myth. So whether you look at the American Academy of Pediatrics, if you look at the CDC, we've done thousands upon thousands of studies, and there is no connection to immunization and autism spectrum disorders. It is well overblown. So it's safe for you to have your child get their shots. So what about treatment? So treatment comes in many different ways. It comes in the form of cognitive behavioral therapy or strictly behavioral therapy sometimes. We use communication training, parent training, and community integration. And in some cases, we add medication management. And that isn't because the medication is directly addressing autism, but it might help with other things. For example, an off-label use of a drug called Abilify, which is a mood stabilizer. It works for bipolar disorder, but it also works for addressing some of the impulsivity that we see with individuals on the autism spectrum. So that's just one example of a medication that can be used to help treat some of the symptoms of autism. However, we have no treatments to date that reverses the autistic pattern. So there's no cure for autism. It is a lifelong treatment. So let's start with cognitive behavioral therapy. So cognitive behavioral therapy might include working on speech, social skills, classroom management skills, self-help skills, activities of daily living. And the way this oftentimes works is you see operant conditioning. So a behavior is done and you reward it, or you might extinguish a behavior like self-injurious behavior. That's operant conditioning. We also have modeling. Modeling is a powerful tool where we show what we expect and we ask the child to do it, and then we reward them based on their ability to emulate the behavior. So that's modeling. Typically, treatments start early in a child's life. And what we have found is that early detection and early treatment results in better prognosis. Remember, we said that there's the potential for some significant disability across the lifespan. So the earlier we can detect it, the better. So we have something called early intervention and See It, things like that, which are designed to target birth to 3 to 5, because we can close the gap to some degree. So you will see a lot of these cognitive behavioral interventions, these speech, OT, PT, all of these allied services start to occur very early, and the earlier the better. Now, schools have also understood that the rates of autism spectrum are increasing. So they're now trying to train their staff on how to work with individuals on the autism spectrum and to provide a proper environment. However, what we see is that it's not a perfect training, and a lot of school districts remain poorly equipped to deal with the needs of individuals on the autism spectrum. So what about communication? About 1 out of 2 individuals on the autism spectrum will remain nonverbal or speechless. So we have to find ways to help an individual on the autism spectrum communicate. Now, this is oftentimes done by teaching sign language. But more recently, we've developed communication boards and computers that help using symbols to represent their feelings, their needs, their wants. So these communication boards have been quite helpful in augmenting the language needs of individuals on the autism spectrum. Parent training. Now, parent training is twofold typically. One aspect of parent training is to make sure that the parents know how to apply these behavioral techniques in the home. So the parents are involved in the treatment of the child, and that allows for treatment to occur 24/7. But we also recognize that having a child with special needs or on the autism spectrum can be difficult. So a second aspect of parent training is to help parents deal with their own emotions and learn how to cope better and be able to identify their own needs and serve them better. So parent training is to help with the child and help with themselves. And then last but not least, we also recognize that we need to be able to generalize learning from the school or from the home into the community as a whole. So you might see community rehabilitation programs or ComHab, where the goal is to take an individual on the autism spectrum into the community and teach them life skills like shopping and ordering off a menu, paying, etc., basic work skills. All of this is going to help the child as they get older. And one of the understandings is that eventually these children, their parents are going to get older and older and older, and they're going to be less able to directly take care of the needs of the child. So if we can integrate community services, then the child will learn a little bit better. So we do ComHab, but we also have specialized homes. I don't want to call it a group home, but there are some group homes that are available where multiple individuals who have special needs either live together under some supervision, or the higher functioning individuals might live independently with someone just checking in on them. And the goal is to have the least restrictive environment. So if the child on the autism spectrum is higher functioning, we don't want to limit their decision making beyond what is necessary, right? So that's one of the pieces of community integration. So I hope this video was helpful. By the end of the video, you should have understood how the DSM-5 integrated multiple conditions. You should have understood some of the hallmark features of autism spectrum disorder, some of the common explanations for where it comes from, as well as some treatments. Now, I will say the treatments we talked about are just a select few. There's over 400 recognized treatments for autism spectrum disorder. So if you like this video, if you found it meaningful, as I asked in the beginning, please hit the like button, subscribe, click the notifications tab. YouTube's algorithm looks at this to make sure that it is meaningful, and it helps us reach a larger audience and helps me fulfill my mission to make psychology accessible to all. Take care, everybody. Be well.